Right, so today we're going to talk about the endocrine disorders, and so first we're going to talk about some of the normal stuff about the endocrine system, and then move into the different disorders. So endocrine glands are glands that secrete hormones directly into the blood, as opposed to exocrine glands. Exocrine glands are going to secrete hormones into a duct. And so some of the endocrine glands that are secreting hormones directly in the blood would involve the pituitary gland, the adrenal glands, the thyroid glands, the parathyroid glands, the pancreas, the gonads or testes, or the thymus. The main functions as we're looking at the endocrine system is that it does a number of different things. It's going to help with differentiation of the reproductive system, as you know, the central nervous system of the developing fetus. It's also going to stimulate growth and development during childhood and adolescence. It coordinates the male and female reproductive system. It maintains that optimal internal environment throughout the lifespan, meaning that it maintains homeostasis. And so we'll see that in the different conditions that we'll talk about, there not being enough thyroid T3 or T4 levels, or being too much of the T3, T4 levels winds up causing a number of different problems. And so we'll talk about this in a little bit here. And then it initiates changes or responses to occur when energy demands occur. So hormones, as we know, are then chemical messengers. They're released from a gland. They circulate in the blood to target cells within other glands or tissues. And after they act on receptors, they are metabolized by the target tissue or the livers. And then afterwards, they're excreted by the kidneys. So the way that I want you to think of the hormones is the hormones are being, the initial organ is going to release these chemical messengers known as hormones. And then those hormones are going to go to a target organ and cause the changes to occur at the target organ. Well, the organ that's directly releasing the hormone from the onset might have an impairment or some kind of condition or dysfunction, which results in not enough hormone being available or too much hormone being available. And so then the target organ will then be affected by how much hormone is available. And or we might have a condition where the organ that's releasing the hormone might be just fine, the hormone levels might be just fine, but the target organ is disrupted either by a tumor or some kind of dysfunction. Okay, so it could be a problem from the initial organ, it might be a problem of the hormone not being available, or it might be a problem of the target organ having some kind of abnormal or pathology. So homeostasis, as you know, then, is this balance that we're going to maintain to try and keep all things normal. And so many of these mechanisms that are maintaining this balance are working by a negative feedback loop. And if this negative feedback loop is not working, then there'll be too much of the example that we used in the last slide, too much hormone or not enough hormone available. So this negative feedback loop then controls the release of these hormones. And anything that we're requiring a normal set point to be at a certain level, then that set point could be changed, okay? So the signals from a sensor trigger changes that occur, and then that continues to raise the level up to a set point in which the body operates functional at a most functional level, and then that hormone or that release is then reduced. So examples would be weight. Once we reach the ideal weight, then we try to maintain that ideal weight, and so our body is going to be much more comfortable at that ideal weight. Acid base, if we have an acid base 7.35 to 7.45, anything that goes above that, we're going to try and cause changes to occur to reduce that level of base. Thyroid regulation is another example that we'll see in a little bit here, related to the negative feedback loop and trying to maintain that T3 and T4 level. Main players that are involved are these right here, so the hypothalamus, pituitary, thyroid, and the adrenal glands. So again, we're we're talking about substances that might be released from the brain. Okay, and so we'll talk specifically then about the hypothalamus causing changes to occur. So in the last slide, it's showing you where the hypothalamus is, and that hypothalamus would be right where the diencephalon is on the picture here. Okay, so the thalamus and the hypothalamus are the diencephalon area. So basically in the center of the brain, center of your head. So that's where the hypothalamus is going to cause changes to occur to the posterior pituitary. And so the release of two hormones are represented by the posterior pituitary, and the release of a few hormones, 1, 2, 3, 4, 5, released from the anterior pituitary. So for the posterior pituitary, we have antidiuretic hormone, which we talked about previously. That's going to control the levels of body fluids by altering the permeability at the kidneys, specifically at the distal convoluted tubules and the collecting ducts. Oxytocin is another hormone that's released by the posterior pituitary, and what it does is allow for contraction of the uterus during labor. It also allows for the milk letdown for females that are feeding their infants, feeding their babies. In the hypothalamus, the anterior pituitary, a number of different hormones here. Adrenocortical hormone, or ACTH, is one, and that stimulates secretion at the adrenal cortex. Luteinizing hormone is another that's going to promote ovulation, progesterone, and testosterone. Follicle-stimulating hormone is going to promote the development of the ovarian follicle and the secretion of estrogen in females, and in males, the sperm maturation. Growth hormone is another one, and that's going to stimulate the growth by increasing the protein synthesis, fat mobilization, and by decreasing the amount of carbohydrate utilization. Prolactin is another one, and it stimulates milk secretion and maintains that corpus luteum and progesterone secretion. So if we don't have enough hormone available, then we wind up with a deficit. And so again, I gave you the idea of it's the organ that is secreting that hormone, and/or the target organ that's taking in that hormone and needs that hormone. So, for example, then if we have a low thyroid hormone level, that could result from a pituitary problem or a thyroid gland problem. So, pituitary problem would be the organ that's releasing the hormone, and/or the thyroid gland might be involved. And so, if it's a pituitary problem where the organ that's releasing it, then we wind up with not enough thyroid-stimulating hormone, and because of that, then at the target organ, which is the thyroid gland, we wind up with decreased T4 levels. At the thyroid gland, if the thyroid gland is the problem, there's actually too much thyroid-stimulating hormone available. It's just that it's not being absorbed or used by the thyroid gland appropriately, and that might result in decreased T4 levels. Antagonistic hormones is the term that we use for hormones that are going to have opposite effects on tissues or substances. So, for example, parathyroid hormone and calcitonin, and both of these are going to try and change the levels of calcium, and if they are going to counteract each other. And so, for example, the parathyroid hormone is going to increase the calcium levels in the blood, whereas the calcitonin is going to decrease the calcium levels in the blood. And so there's this fine balance related to homeostasis in which we're trying to maintain these levels, but the hormones are going to then directly affect that. So if we had too much parathyroid hormone, for example, present, then we're going to increase that calcium level, and the calcitonin levels will need to increase if there's too much parathyroid hormone, because then we might have too much calcium available. If they do not increase the calcitonin level, then the decreasing of the calcium is not going to take place, because there would be too much parathyroid hormone producing too much calcium. So endocrine disorders, we might have too much of the hormone available, we might have not enough hormone available. And so examples of what might cause too much hormone to be available would be that the gland itself is a problem, and/or the individual is taking in too much of the hormone from the outside source, possibly from a diet, for example. If there's not enough hormone available or too little, then we wind up with a deficit, and that can come from decreased quantity of that hormone. It can also come from the resistance of target cells to the hormone. So there might be a genetic defect, for example, or an autoimmune response, or an excessive demand on the target cells, and they can't respond as well. The clinical manifestation of the disorder then is going to depend on the original action of the particular hormone, which means the signs and symptoms that we're seeing in our patients then are going to be directly related to how much of the hormone is available. Is there too much? Is there not enough? So the most common cause of endocrine disorder are going to be from an adenoma, and so that would be a tumor, and it could be a malignant or a benign tumor. Okay. If there's a secretory problem, then we wind up with excess hormone. But if we have a destructive process, so for example, if the hormone is pushing on the gland, then that might cause a hormone deficiency or neurologic effects. And we'll see this in a couple of different conditions as we get to the end here, related to twitching and tetany. Other causes of hormone diseases might be a congenital defect of the gland itself that's producing the hormone. We might have hyperplasia of the gland, which is again producing the hormone. It may be an infectious process of the gland. We might have an immune reaction in the area that's specifically affecting that gland, or vascular disease, the blood supply to that gland that's secreting the hormone. So diagnosing the hormonal disease is usually done by a number of different things. In physical therapy would be involved with the physical exam. And some of these things that you'll see in the pictures, we can note and specifically identify some of the clinical manifestations that correspond to the conditions that the patient has. Other things we're not doing directly, and that would be blood tests, urine tests, stimulation or suppression tests, so increasing the amount of hormone available or decreasing the amount of hormone available, ultrasound MRIs, and biopsies. For blood tests, when they look at this, they're usually looking at the hormone levels that are available. And so tropic hormones from the pituitary, they would be looking at, for example, thyroid-stimulating hormone or luteinizing hormone, and or hormones from the glands themselves, so T3 or T4 levels and or estrogen. When they do urine tests, they usually actually do, instead of a one-time urine test, they wind up doing a 24-hour urine test to get a better idea of what hormones are available or not available. So the treatment of endocrine disease then is going to depend on the cause. For example, if we have not enough hormone available, then they're going to try and replace that amount of hormone. So, for example, hypothyroidism, they might give Synthroid or levothyroxine. In type 1 diabetes, they might give an individual insulin and Ovalog. In type 2 diabetes, they might give the individual glucophage or metformin. If the endocrine disease is bad enough, they might do surgery or radiation. So specific disorders that we'll talk about here, the endocrine disorders, we're going to talk about each one of these, except for diabetes mellitus, because we have already spoke of this in the previous lecture. For parathyroid disease, we need to review the calcium metabolism. And so the hormone factors that are involved in the calcium metabolism are parathyroid hormone and calcitonin, as we talked previously about. And then the non-hormone factors would be the vitamin D and phosphate. So are we getting enough sunlight? Do we have enough vitamin D intake in our body? Do we have enough phosphate in our body to produce calcium? So calcium metabolism then is, as we review this, then the body's going to sense the levels of calcium in the blood. If we have not enough calcium available, then we are going to want to increase the calcium levels in our blood. How do we do that? We increase the uptake of the calcium from the gut. We increase the calcium reabsorption from the kidney. We might increase the release of the calcium that's directly coming from the bone. And because of all of these three steps, then the calcium levels should go up as a result. And then the increased calcium will turn off the secretion of parathyroid hormone from the parathyroid glands. So both of these then are going to work opposite of each other. And again, that's basically what's happening for a negative feedback loop. So the condition here would be hypoparathyroidism, and so this is showing the cervical spine of an individual, specifically an anterior view, and showing where the parathyroid glands are located in the pictures. And so etiology, we might have a congenital lack of the parathyroid glands, we might have post-surgery or radiation, or autoimmune disease that's going to affect the parathyroid glands. The outcome winds up causing not enough calcium available. And so to maintain these specific levels of calcium that we need for many functions, then that's constant interaction between these two, the parathyroid hormone and the calcitonin. And so again, both of these are going to work as antagonistic hormones, and they're going to result in opposite effects of the calcium levels in the blood. And so if we have this in disarray, then hypocalcemia may cause weak cardiac muscle contractions. And so if that's occurring, the heart's not going to contract as well as it normally would. And hypocalcemia then is not going to cause weak skeletal muscle contractions. And the reason why it would be that the heart muscle is cardiac muscle, and the skeletal muscle is not cardiac, and so it doesn't need the levels of calcium that we need for the heart. It also would result in increased excitability of the nerves. So this is what I said previously about the tetany, or the twitching and spasm. And if you remember, Chavott's sign would be if you tap to the lateral portion of the eye, it results in a tetany response or twitching. Hyperparathyroidism etiology is just the opposite then from hypoparathyroidism. The etiology of this would be maybe a tumor, hyperplasia, renal failure. Outcome for this is not hypocalcemia, but instead hypercalcemia. And so what happens when we have too much calcium available? We wind up with these very forceful cardiac contractions. The calcium is going to leave the bones, and if the calcium leaves the bones, then that sets the individual up for increased likelihood of fractures or osteoporosis. It also sets them up for an increased incidence of kidney stones because there's too much calcium available, and the calcium will then form calculi or kidney stones. Growth hormone disease that might result in short stature or tall stature. For short stature, there's not enough growth hormone available. Specifically, growth hormone is known as somatotropin. It's released from the pituitary, and this release is then governed by somatotropin-releasing hormone from the hypothalamus. One of the causes might be a pituitary adenoma, and that will result in normal body proportions, but delayed skeletal growth and a delay of puberty. In tall stature, we wind up with two different situations, gigantism and acromegaly. And in gigantism, there's an excess amount of growth hormone that occurs prior to puberty and prior to the fusion of the epiphyses. Acromegaly, there's an excess secretion of growth hormone in an adult, and it's usually secreted by an adenoma. And these individuals will have broader bones, enlarged hands and feet, but a protruding mandible and a large tongue. So these are both pictures of individuals with this condition. In thyroid disease, we'll talk about two different types, hypo and hyper. And so thyroid gland, just to orient you to this slide then, when we look at this, the hyoid bone is right here. And so the thyroid cartilage then sits down below it, and the hyoid bone, if you swallow, then will move, right? And then around it, we have the thyroid gland right through here. And so the thyroid gland on the individual here would be right there. Okay. So the general function of thyroid is that the thyroid gland is going to make two hormones, thyroxine, which is T4, and iodothyronine, T3. Sorry. The hypothalamus is going to produce thyrotropin-releasing hormone, or TRH. That's going to directly go to the pituitary, and it'll stimulate the pituitary to produce thyroid-stimulating hormone. Okay, that thyroid-stimulating hormone will stimulate the thyroid gland, so it goes to the thyroid gland, and then produces T4 and T3. Okay, the thyroid gland converts the iodine actually into T3 and T4, and the thyroid hormone then is released in the bloodstream. So it looks like this. The hypothalamus is going to produce thyroid releasing hormone. That will go to the pituitary. That will produce thyroid stimulating hormone. That thyroid stimulating hormone, the iodine will convert over into T3 and T4 levels. The T3 and T4 levels will go out into the bloodstream. Okay. So inspection of thyroid, when this is done, to inspect the thyroid, you tip your head back slightly, and you make sure there's the room and the light in the room is well lit. You ask the patient to swallow. When they swallow, the thyroid will move up and down. May identify more abnormalities such as asymmetry when the patient swallows. So it's better to actually have them swallow. So if we look at the picture here, a normal thyroid at rest on the left, and then swallowing. So it's just showing you the picture of the thyroid moving along or moving up with the swallow. An abnormal thyroid at rest versus swallowing, that thyroid gland does not move. And so that's what this picture is trying to show you. Goiter is another condition. It's a chronic enlargement of the thyroid gland. It's usually not due to a cancer. It can be due to normally low thyroid hormone secretion due to a lack of iodine in the diet. And so if iodine is not available in the diet, then the individual winds up with goiter and results in low thyroid hormone. So this is showing you the enlarged area there of the thyroid gland. And why it's not common is because most of the time we're taking in enough iodine into our diet. Generally, it's not uncomfortable, but obviously, if you look back at that picture, that could interfere with swallowing or breathing. It's more common in females and older adults. When it's enlarged, the thyroid may produce below normal, or above normal amounts of hormones. In other words, you're going to see all kinds of different levels. We might not have enough. We might have normal. We might have too much of the T3, T4. It's associated with either hypothyroidism or hyperthyroidism. So in hypothyroidism, there's not, and goiter in hypothyroidism, there's not enough dietary intake of iodine. Iodine is used by the thyroid gland to manufacture T3 and T4, which we've said before. And when T3 and T4 levels are low, it's going to trigger a rise in the thyroid stimulating hormone. And this overstimulation of the thyroid gland by the thyroid stimulating hormone causes the gland to hypertrophy. And that's why we see that picture of the lady with the enlarged adrenal glands, thyroid glands. In hyperthyroidism, then there's excessive stimulation, and that can cause the gland to become large and nodule also. So hyperthyroidism, classic here, showing you Barney Fife from the Andy Griffith show. If you've seen that show, you'll notice some of the signs and symptoms. And so exophthalmos is the bulging eye. So in both of these pictures, you can see that the eyes are bulging. These individuals, they have flushed, warm skin. They don't tolerate the heat very well. They have a rapid heart rate. They're usually anxious and nervous. If you've seen the Andy Griffith show, then that correlates well to Barney Fife. And they are usually thin. They have increased appetite, and they commonly have diarrhea. Graves' disease is the most common form of hyperthyroidism. It's an autoimmune disease in which the antibodies will cause too much T3 and T4 levels to be available. And so this is one of the most common types of hyperthyroidism, and that winds up non-painful. There's a non-painful swelling of the thyroid gland, but there's too much of the T3 and T4 available. So if there's too much of T3 and T4, then the metabolism rate is going to be really high, as opposed to hypothyroidism, in which it's really low. The treatment for hyperthyroidism is usually radioactive iodine. They may have surgery, or they might be on anti-thyroid drugs. Post-treatment, because of the change that occurs after the treatment, they might have drastic fluctuations and result in hypothyroidism or hypoparathyroidism. So hypothyroidism is very common compared to hyperthyroidism. And so these individuals are going to be just the opposite. Their metabolism is going to be slowed down because they don't have enough T3 and T4. So they'll have pale, cool, dry skin. They might not tolerate the cold very well. They dry, brittle hair. They'll be fatigued quite a bit. They wind up with constipation versus diarrhea that we saw in hyperthyroidism. They wind up with fogginess or decreased thought processes and weight gain. One of the most common for hypothyroidism is Hashimoto's thyroiditis, and that is going to destroy the thyroid gland because this autoimmune disease attacks and destroys this gland, and then that causes not enough T3 and T4 to be available. Treatment for this is usually Synthroid or levothyroxine. It usually takes, when they start off the medication, it takes about 8 weeks to stabilize. After the treatment, they are going to have an increased risk of hyperthyroidism because the hypothyroidism now, there's enough T3 and T4 available. So a couple of different pictures showing you before and after treatment. Adrenal gland disease, the adrenals are going to sit on top of the kidney. There are two portions, the medulla and the cortex. The medulla is the middle part. The cortex is the outermost part. The medulla makes epinephrine and norepinephrine. The cortex is going to make steroids. Which ones? The glucocorticoids and the mineralocorticoids. And so the glucocorticoids, I want you to think of cortisol as one of them. So it's essential for the stress response of flight and or fight. It's essential for life, and if we have too much of it, it's going to cause negative effects. The mineral corticoids, I want you to think of aldosterone. So aldosterone, we've talked about previously, is going to be involved in trying to keep those sodium levels at an optimum level. And so anywhere salt goes, water goes. So if we have a problem with too much sodium, then we wind up with blood pressure problems. Or if we don't have enough sodium available, then we wind up with blood volume problem. Adrenal gland disease, there's two different types. The cortical disease would result in Cushing's. We could have Cushing syndrome or disease, and we can have Addison's disease. So we'll see pictures here in just a second here. In Cushing syndrome, there's too much cortisol that's available. It can be caused by a tumor or the taking in of cortisone. In Cushing's disease, there's excess amount of cortisol available, and it's usually, we know what causes that. That's pituitary adenoma. In Addison's disease, there's not enough cortisol. So the difference between Cushing's and Addison's would be the amount of cortisol that's available. So here's an example then for Cushing syndrome would be the signs and symptoms. They usually have a moon face or a enlarged face. They'll have a buffalo hump in the area where the cervical and thoracic spine meets. There's an excess amount of fat that occurs on the back of the neck there and the cervical spine area. They have muscle wasting in the limbs, fragile skin, flushing of the cheeks. Hirsutism would be, they would also have excessive hair growth or broad striae, which is another name for stretch marks. In Addison's disease, there's not enough adrenocortical steroids. In these individuals, the etiology could be autoimmune, infection, a hemorrhage, and or tumors. Okay, and so what we wind up seeing with this then, we have a deficiency of glucocorticoids, mineralocorticoids, and androgens. And so because of that, remember I said for glucocorticoids, I want you to think of cortisol that causes an increased ACTH secretion. And that results in the signs and symptoms of hyperpigmentation that the skin creases on the face, as you'll see in a second here, on the extremities, the mucosa, and or the tongue. In mineralocorticoids, it results in aldosterone changes to occur, which again is going to affect the retention of fluid. Androgens are going to result in decreased body hair. So signs and symptoms wise, then these individuals will have decreased blood glucose levels, poor stress response, be tired, weight loss, they may have infections, hyperpigmentation. You can see this on this individual in the picture, anorexia, nausea, diarrhea, low blood pressure, which may lead to fainting. Okay, so this is conclude the endocrine lecture, and hopefully you've learned a few things about the different disorders that occur with endocrine system.